targeted therapy and the development of targeted therapy has not been particularly successful historically in urothelial cancer. We've run a number of trials. Many of those trials, almost all of those trials, have been negative, and they range from Herceptins to Pazopanib, single agents and combinations, selected and unselected. But there has been one notable exception to that, and that is the combination of ramucimumab, which is a monoclonal antibody to the VEGF receptor, in combination with docetaxel. That combination has outperformed docetaxel alone in randomized phase 2 studies, and most recently in randomized phase 3 with progression-free survival as the primary endpoint. The overall survival signal is less robust than we saw previously in the randomized phase 2, which is often the case, but the curve still suggests some benefit, although that's not statistically significant. One of the difficulties with that is what does that actually mean for patients? Well, we know that by the addition of the second drug, we've proved the hypothesis correct that VEGF in a randomized phase 2 and phase 3 can validate the importance of that target in urothelial cancer, and that's important for today and tomorrow. But also in this unusual area of huge unmet need, where chemotherapy alone has very modest activity, any improvement seems to me to be a step in the right direction, particularly as, number one, there are so few alternatives, and number two, as the combination seems well tolerated. So I look at this as a treatment option. It hasn't hit that high watermark of overall survival, but we've also had immune therapy studies that haven't necessarily hit that high watermark as well, and have resulted in approvals. And I do see this as an area of drug activity and a promising combination, which I think does have a place. Whether or not that place is modest or very large remains to be determined, and the clinical community will need to make that decision. I could see myself using this rather than single agent taxanes, for example, but you might say, how often are we using single agent taxanes now with drugs like the FGF inhibitors, the antibody drug conjugates such as efortumab vedotin, and the third group of drugs, the other immune targeted therapies which are ongoing. So because the landscape's changed so quickly, the footprint caused by this is perhaps less than it would have been 5 years ago, but nevertheless this is a step in the right direction.